Good afternoon. My name is Dr. Hansen. I'm one of the pediatric neurosurgeons practicing here at Cook Children's and a member of our epilepsy team. I'm here this afternoon to speak to you about some of the more recent advances in the minimally invasive treatments that we have for epilepsy. Maybe the slides will go. Aha. We're going to cover three main topics today in the brief time that we have together. We're going to be talking about SEEG, or stereo EEG. We're going to be talking about RNS systems, or responsive neurostimulator systems. And last but not least, we're going to be talking about LIIT, or laser interstitial thermal therapy, or laser ablation. This is not a comprehensive review of all of the minimally invasive techniques that are available for children today, but it's a handful of the more common ones. I also want to preface this talk by saying that what we're going to be talking and discussing today are not necessarily options for all children with epilepsy. As I'm sure all of the parents and families of children with epilepsy are aware, everybody's seizure activity and epilepsy is a bit unique to themselves. And so not all of these are options or available for your child. But I want to encourage you, should you have any questions about what we're talking about today, or whether or not your child would be a potential candidate, to speak to your treating epileptologists in more detail. Our first topic today will be stereo EEG. The really fancy term for this is stereo electroencephalography. It's a mouthful even for myself. What it basically means is taking recordings that we would have typically gotten from the scalp from inside the brain instead. This is a type of surgery that we will offer to children who've already undergone a thorough epilepsy evaluation. When we think about evaluations for seizures and epilepsy activity, we think of them in phases. Phase 1 testing is non-invasive testing. This is testing that can be such simple things as scalp EEGs, MRIs, PET scans, MEG scans, things that do not involve invasive testing of your child. Oftentimes, phase 1 testing reveals sources of epilepsy or causes of epilepsy, and no additional evaluation needs to occur. But for some children where phase 1 testing is not specific enough or does not give us a focused enough answer, phase 2 testing or invasive testing may be in order. Stereo EEG is one of the newer techniques in invasive monitoring that has come about in the last several years. Stereo EEG involves us placing very small millimetric-sized wires through small openings in the skin and the skull, deep down into areas of the brain that are of interest to us to record from. When we think about doing a stereo EEG, a lot of planning actually goes into the placement of the wires and where we want to record from. Prior to surgery and prior to any intervention, we obtained very detailed CTs and MRIs of the child's brain to help us understand the anatomy of the brain underneath and where exactly we can place these wires safely into the brain to acquire the information that we need about the child's seizures. These plans are developed between close communication between the epilepsy doctor, the neurologist, and the epilepsy surgeon, the neurosurgeon. Together, we will come up with an implantation plan for where all of these wires need to go. Electrodes can be placed into very deep structures of the brain where we are unable to get recordings from just using scalp electrodes. Typical implantations are somewhere between 8 and 12 wires into various regions of the brain for us to get information from. On the actual day of surgery, your child will go to sleep, go into the operating room. We'll have a special device placed onto his head to hold it very still, and then using a very sophisticated robot to help us hold our instruments and to allow us great precision and accuracy, the wires are placed down deep into the brain using the plan that we had made beforehand. This surgery takes a few hours. The child is asleep for the entire experience. And then afterwards, the child is taken out of the operating room, back up to the EMU, or the Epilepsy Monitoring Unit, where the child will remain for several days while we obtain seizure activity and electrical activity from the brain. The robot that we use at surgery is this giant red device over to the right of the surgeon who's standing in blue behind the child. That robot has an articulating arm that holds our instruments with utmost precision, allowing us to do these surgeries very safely. These are two pictures of what your child might look like after surgery. These are temporary caps that are placed on the devices that help hold the wires into place. But at our institution, we don't shave any of the hair. The children are left with no large markings. They're not left with anything that looks scary or abnormal or would be disturbing for them when they wake up. As I mentioned briefly, after surgery, your child is taken to the Epilepsy Monitoring Unit, and as all of the wires that we have placed are attached to very sophisticated machines to help record the electrical activity coming from your child's brain. How long that recording period goes on depends on your child's seizure activity. For us to have the utmost confidence in where the seizures are coming from and our subsequent recommendations for you on treatment, we would like to see several seizures before we stop the monitoring period. Depending on the frequency of your child's seizures activity, that may be 1 or 2 days or 1 or 2 weeks. It is sometimes difficult to predict after a child has had anesthesia for surgery exactly how long that period will be. Once we've recorded enough information, we'll take the wires out and the holders that keep them in place. That second surgery is much simpler and much more straightforward than the first surgery. It lasts only 30 or 40 minutes. The child is asleep for it so that it's not disturbing for them. And afterwards, the child recovers very quickly. Most children are able to go home that very afternoon after the wires are taken out of their head. Very often, after the recording period is completed, the child will have the wires removed, will go home, and we will not have a definitive plan for surgery or for additional treatments at that time. Once you've gone home, the epilepsy team as a group will sit down in a big conference, review the electrical activity that was acquired during the stay, and then we will come up with a treatment plan. At that point, you and your child will come back to the hospital and sit down with the epileptologist and the treating surgeon to discuss what those options might be. That was a whirlwind dive into stereo EEG. There's a lot more detail that can be covered, and there's a lot more subtleties that go into the actual planning and the surgery. So again, if you have questions, please feel free to reach out to your treating epileptologist. We're going to move on now, though, to something that is even newer and even more on the cutting edge than stereo EEG. This is something called RNS, or Responsive Neurostimulation. This procedure involves implanting a device into the skull to send an electrical signal to the surface of the brain or the depths of the brain where seizure activity may be arising to hopefully stop it before it spreads into a noticeable seizure. This is a picture of the device itself. The device that you're looking at is about 1/3 of a size of a pack of playing cards. The electrodes that are attached to it, which are the paddle-like device with 4 small dots and the long wire-like device, are on the order of about 1.5 inches in length, just as a comparison for size. This was a device that was designed to aid in the treatment of drug-resistant epilepsy. It is usually not a replacement for medications, but it is an adjunct or an addition that we can use for patients who are still having seizure breakthroughs, even on appropriately dosed medications. This is a device that we particularly look at using when seizures are arising from areas of the brain that would not be safe for us to operate on. Areas such as those that control motor functions, or speech functions, or vision functions. This is a very general schematic of how the device is used. The battery and the generator itself sit within a small tray that is implanted into the patient's skull. This is in the bone of the skull, but it is above the surface and the covering of the brain. It is not actually in the brain itself. The tray and the device sit flush with the skull so that once surgery is complete, you would not be able to feel or notice the device from the outside. The electrodes, or the stimulating part of the system, the part of the system that delivers the electrical current to the brain, can sit either on the surface of the brain or deep down inside, depending on where we think the seizures are arising from. As I mentioned, the device hides under the skin, both the electrodes and the generator. And the battery, which powers the entire device, lasts on average 8 years. Depending on how frequent the device is sending signals, depending on how strong the signals the device are sending, can influence the battery life. It can be shorter, it can be longer, but on average it's 8 years. At the end of its lifespan, for the device to continue to function, does require a secondary surgery to replace the battery, although the secondary surgery is much more straightforward and simpler than the first. After this type of surgery, just like the first surgery, no hair is shaved. There is no significant incision from the outside. And children stay in the hospital for a period of 1 or 2 days, recovering afterwards, although the majority is just 1. After surgery is actually where most of the work is involved. The child and the family will be provided a special device that looks like a little handheld wand and a laptop. After surgery, that will be able to connect to the device that's implanted in the skull to download the activity that it's recording over time. That laptop will then send all of that information and the electrical activity to your treating epileptologist, who's able to review that activity and then make changes to the device to hopefully better control your seizures over time. Downloading is a painless process. It takes only a few minutes, and all it requires is holding the device over the area where the implant is for a few minutes. The picture down at the bottom of the screen is just an example of what we see on a physician side of the activity that you are downloading from your device. We see all of the electrical activity that those electrodes are able to record. We're able to see where your brain is having periods of normal electrical activity, and we're able to see where there are periods of seizure activity, seizures that you may be aware of at home, or abnormal electrical activity that you may not even be aware of. Based on all of that information that's collected, your treating physician is able to make small adjustments to when the device sends stimulation, how strong the device sends stimulation, and what sort of electrical activity to watch for to try and treat. All of these signals that the device sends are imperceptible to the child. They do not feel them. They do not notice that the device is going off. It causes no discomfort and no change in their regular activity. In this manner, watching your electrical activity over time and being able to change the settings of the device, you can think of the device as learning about your specific type of epilepsy. As the device learns about your type of epilepsy and we're able to change how it stimulates, most patients see a significant decrease in their seizure activity over time. This is just a representation of one patient with a log of their seizure activity over weeks and months. And as adjustments were made to the device, at the end of the graph, you can see how their seizure activity finally tapered off and stayed low for the remainder of the monitoring period. This does mean continued follow-ups with your epilepsy doctor, but the benefits over time can be very, very impressive. Some children are able to wean off some of the medications that they have been on once the device is successfully functioning. As I mentioned at the beginning, an RNS device is not a replacement for all of your medication. And for most kids, it will not be a replacement for all of their medication, but it may be a replacement for some of them. This is something that will be discussed and followed and monitored over the course of time with your epilepsy physician. Once again, that was just a very brief and very quick overview of the RNS device. There are a lot more technical features, and there's a lot more data that we can talk about the specifics of what percentage of patients respond and what don't, and how those things change over time. But that's a little bit too in-depth for the discussion that we're having today. But your epilepsy physician or myself would be happy to discuss any of those should you have additional questions. The last topic we're going to talk about today in our brief time together is what's known as LIIT, or laser interstitial thermal therapy, or laser ablation. There are two main companies out there providing services for this type of treatment. You may have heard of their trade names as well. But in general, today we're going to talk about laser ablation when we're talking about this. Yes, we are talking about putting a laser into your head. It's a treatment option, potentially, for places that are small, that are deep, or that are near areas of the brain that we need to protect from damage. It's also sometimes an option for patients who are otherwise medically fragile and wouldn't be able to tolerate a larger, more stressful surgery on their body. It uses a laser, or a very, very, very targeted application of thermal energy to destroy tissues that are causing abnormal electrical activity. This picture is just a small idea of one of the devices that is available on the market. In the surgeon's hand, you will notice a small little bolt-like device with two little wings. That is the device that actually screws into a small hole in the patient's skull. And then the wire that you see protruding out of it is actually the laser catheter. It's a small fiber optic cable that is directed down to a target within the brain. It is then connected to a generator that creates the actual laser that allows heat to be generated at the tip of the device, destroying surrounding tissues. The hole in the skull that's used to secure the device is only several millimeters in size. It's barely imperceptible from the outside. And the incision that we have to make in the skin is able to be closed with a single stitch. Placing the laser is not something that happens in a vacuum. There's a lot of planning that goes into treatment before the child ever reaches the operating room. On a very specialized computer program, our target deep within the brain, and sometimes on the surface, is picked with high accuracy on a very precise MRI that will be obtained before surgery. Then, using our target, we are able to find a trajectory or a pathway along the brain that avoids other critical structures, other important blood vessels, places that we need to keep safe on the laser's path from the outside to the inside. This target and this path are decided after a close conversation between the treating neurosurgeon and the treating neurologist. Once the laser fiber is in place, this treatment occurs in an operating room that has an MRI attached to the operating room or nearby. Once the wire is in place, the child will be taken into the MRI suite, where we are able to obtain very precise images of where the catheter or the laser is, and the heat that is generated by it as the laser device is turned on. The picture on the left is just a picture of some of the monitoring software and equipment that we have to ensure safety of the dose of laser that we're turning on. and the extent of the heating into the surrounding tissues that we achieve. The picture on the right is several images of various patients who are currently undergoing or have undergone laser ablation of structures deep within their brain. The thin little black lines that you see traveling through the brain are the laser wire itself that we're able to see on the MRI. And on several of the pictures, you will see bright areas of bright white or bright gray scattered amongst the darker areas. And those are areas that we have treated using the laser, and we're able to see physically what areas and what regions we have affected using the laser and the energy it produces. All of this is done in real time, so that as we turn the laser on and as we hit the power buttons, we are able to watch the tissues of the brain and the exact temperatures they're at and exactly how far that heat's expanding, so that we know that not only are we getting the areas that we want to, but that we're able to protect those areas around that need not be damaged. For certain patients, a single laser is not enough to treat the area of suspicion. For certain patients, we will use 2, 3, and in rare cases, even 4 laser fibers to adequately cover the area that we want to destroy using the laser. After surgery, as I mentioned, everything is removed and the little hole in the skin is able to be closed with a single stitch. Children are observed in the hospital overnight, and more than 90% of them go home the following day. They have minimal pain, except for maybe a slight ache at the surface of the skin. They're able to return to full activities within weeks, if not sooner. And most of them return to school within only a few days. I mentioned at the beginning that our time together today is very short. So this is just a small sample of all of the treatment options available for epilepsy, and certainly just a small sample of some of the less invasive or minimally invasive options that are being advanced every day in epilepsy centers across the country. Also, as I mentioned at the beginning, not every epilepsy treatment is appropriate for all patients. This is something that can really only be decided in conjunction with and in partnership with your treating epilepsy doctor. Here at Cook Children's, we have a comprehensive epilepsy program. So if you have any questions about what I discussed today or about other potential treatment options for your child, please don't hesitate to reach out to us. We are happy to talk anytime. Along with 2 of our fantastic treating epilepsy physicians, Dr. Scott Perry and Dr. Cynthia Keeter. It has been my absolute pleasure to talk to you today. Again, I know this was quick, and I'm sure there are many things that you wanted to hear about that you did not today. And I'm sure that it generated for some of you questions about these treatments and the options. Again, please don't hesitate to reach out and talk to us. It was my absolute pleasure to be here today. Thank you so much for listening to me. Have a wonderful day.